Uh, in today journal club, I selected an article from a journal called the Journal of Addiction Medicine. It is the November-December issue of 2023. It is the editor's choice issue. In every issue, the editor suggests only one article, and in that issue, he selected this one. I liked it, and I felt that it is very interesting to our providers and to our patient for many reasons. We will elaborate on that. The article consists of a consensus uh, agreement on on 6 issues, and they go in from the chronological issue from initiating patients on Suboxone and how to maintain them and what to do if the treatment did not suit the patient, if they failed it. I'm going to skip the first one on about the initiation, but I'm going to substitute that with another more interesting issue that I will get to it at the end of the presentation. And the other 5 issues are the following. Number one, what happen if a patient who that we initiated on Suboxone will experience withdrawal symptoms. Number two, what is a reasonable maintenance dose on for patients on Suboxone? Number three, when injectable Suboxone need to be considered. Number four, what we can do if the Suboxone just failed. It's not working. The patient still having craving to illicit drug. Is still experiencing overdose, and so on and so forth. And what happens when a person on Suboxone experience acute pain? We will address that one in one. Number one, what happens before we go along with what we talked about, we need to understand how Suboxone works. Suboxone is really a narcotic. It is an opiate. However, it is called partial agonist, meaning that it is not full agonist. If the other opiates, we know other opiates like morphine, like oxycodone, like hydrocodone, fentanyl, of course heroin, in the which is an illicit drug. They work on opiate receptors. We have 5 types of opiate receptors. We have receptor means where the medication start to work. We have the mu receptors, kappa, delta, and the nociceptor, and S receptors. Now, the most important thing for our purpose is the mu receptors. The mu receptors, it has also subcategory. We have the mu receptor 1 and 2 and 3. The 1 is does affect pain relief. This is which is the reason that opiates were developed from thousands of years until now. Number 2, the mu receptor 2, number 2, is related to the euphoria, that people feel good with it, and the euphoria and the dependence. and respiratory depression. This is the problem, the respiratory depression, because that's how people die from overdose. And there is other receptors, kappa, that also can cause analgesia, pain relief, but also it can cause dysphoria, meaning it doesn't feel good. And we have patients that we give them opiates for pain. They say, I don't like the way I feel with it, and I don't want to continue that, because apparently their kappa receptors is very active. So now, after the Suboxone, what does it do? It goes to the mu receptors. It does cause analgesia, and to some extent, it does cause the euphoria. The euphoria and the respiratory depression, as I mentioned before, it is partial opiate. That's why they don't feel high and they don't feel euphoric, and they don't have respiratory depression. That's why it is very safe medication. And the reason that it is used in opiate dependence is that it is very long acting. When it goes to the mu receptors, it has very strong affinity to that receptors. It goes there and it stays there. It stays, the half-life is 36 hours. So because the most uncomfortable part of people who became addicted is that when the level of the opiates drops and the mu receptors are empty from the opiates, they feel withdrawal symptoms. With the Suboxone, it goes there for a long time until they get the second dose of the medication. They are fine and they can function perfect. They don't have craving to opiates. They can have their job. They can have their family, their relationship, and they can conduct a normal life. So now that is why it is used for people who are dependent on opiates. In fact, methadone works the same way. But it is full agonist, meaning that patients can overdose on methadone, especially if they added another medication to that, which is, and they cannot overdose on the buprenorphine. Furthermore, the methadone, its metabolism is really funny, because it can be very long, and its analgesic effect is not as long as the half-life of it. So it can affect the heart, the rhythm of the heart, I should be specific. And so that's why and also people need to go to methadone clinic for that, and which can be difficult. So the Suboxone is much easier to use, and it really does the job. So now, the question is that, as I mentioned before, what happened? Many patients ask us that, you know what, do I really need to wait for long time and suffer withdrawal before starting the methadone? And also there is an issue, and they are right, it can happen. Furthermore, there is an issue of precipitated withdrawal, meaning that because, as we mentioned before, that the Suboxone has affinity to the mu receptors more than any other opiates, it can displace the opiate that they are on those receptors, and being only partial narcotic, the people can feel withdrawal. However, this is really fear that is blown out of proportion. The literature said that about only 1% of the people can have precipitated withdrawal. So now the question is, if it does happen, what we should do? The answer is to give more Suboxone. If we give more, then more mu receptors will be occupied with the Suboxone, and the symptoms of withdrawal will be alleviated. This is number one. Number two, there is class of medication called the alpha agonists. They work on the brain. They decrease the norepinephrine and other stress hormones that they are associated with withdrawal. The prime example of it is clonidine. Clonidine is used to treat high blood pressure. So if somebody, we can use it if somebody does not have low blood pressure to start with, because we don't want their blood pressure to decrease further. And if they have normal blood pressure, we can give them 0.1 or 0.2 or even more of the clonidine. They will decrease the withdrawal symptoms, and then that will be those withdrawal symptoms will be alleviated. Better than that, perhaps, is tizanidine. It is a muscle relaxant that does have also alpha agonist, exactly like the clonidine. They are in the same family. It does not decrease the blood pressure, so it is excellent choice for those who have low normal or low blood pressure. It is excellent choice. And as a matter of fact, we don't need to wait until the withdrawal symptoms are experienced by the patient before we give them the clonidine or tizanidine. We can even use it preventatively, and that will alleviate all the symptoms, and the adherence to the treatment potentially can be enhanced. Now the other now we talked about initiation and what happens if we have precipitated withdrawal. Now, what is the normal dose of Suboxone or buprenorphine? I have to use it here interchangeably. We usually start them with 8 to 16 milligram. Perhaps in our practice, more than 95% of the patients, they are in that range, probably closer to the 16 milligram. However, we do see the right dose for the Suboxone is when it does alleviate when it alleviates the craving, or when it enables the patient to not to use illicit opiates or a prescribed opiate that they got him dependent and addicted to the medication. This is typical. So occasionally we do have patients that they require more than 16 milligram. I don't believe there is an issue if we give them more. I mean, we can give them 20 milligram, 2.5 tablet of the 8 milligram, or even 3. Anything more than 3, although it is used sometimes, there is no strong data that it is really beneficial. So we have to be careful, especially because it can encourage diversion, meaning that they sell the extra. Selling the extra of Suboxone is not as bad as selling full agonists, oxycodone and morphine, but it will prevent other patients from going through the medical system, which is safer and better and more controlled than just doing it through family and friends. So what I'm saying in that issue is that we can go above the 16 milligram level. More than 24, it will be really problematic because there is not enough data to suggest that it is of any benefit. However, there is an exception to that, and this is in pregnant women. The pregnant woman, they have very high very high metabolism, so they burn the buprenorphine fast. Furthermore, they have large blood volume and extracellular fluid volume that it has to be considered, and they usually require doses on the high end. We have to take that in consideration. If they tell you that they are still having craving, that don't feel comfortable, they are right. There is a pharmacological reason for that, and we have to give them an increased dose. Now, when an injectable Suboxone is needed, we have currently two medication that are injectable. They are buprenorphine. One of them is Sublocade, and the other one is Brixadi. With the Sublocade, which is it's about 12 years old medication. It's the 300 milligram. After a few weeks, it can cause the blood level that is just as good or not higher than the sublingual, than the one that is used underneath the tongue, and so it is good choice. Brixadi it has weekly and monthly injection. The monthly injection has a component both in Sublocade and Brixadi that can be teratogenic, meaning that it can cause deformity in the fetus, and we should not use it. The weekly Brixadi does not have that compound, and it is safe to use it in pregnant women. But when do we need to use the injectable one? If we have, for example, somebody that has transportation system can't come to the office to get the prescription and to do urine testing or obtain counseling, we should consider the injectable, the monthly or the weekly, whatever is needed. Or if a person who is in environment, a girl her boyfriend still use injectable medication, or a boy that his girlfriend does, and he is in an atmosphere that is conducive to use illicit drug, they will be very good candidate for the injectable form. They are much more expensive than the sublingual, but if they save life, I believe it is worth it, especially the age group of those who die from overdose, that is rather on the young side. So there is a role for that. Now, what happens? The other last question of that expert opinion, the consensus expert opinion, is if Suboxone, if buprenorphine did not work, they kept on being overdosed, they still have craving, and you can tell that it's not really for them. At that time, I believe methadone is very good choice. We can refer them to methadone clinic. We can in our practice we cannot treat them with methadone because the federal law prohibits using methadone for addiction in private offices. We can treat pain with methadone, but not if there is an addiction element to their problem. We have to set them out. There is another medication which is naltrexone injectable that can be used also. However, it has a significant limitation because it is antagonist, and the patients will resist to do that, except if they are really overdose few times and they just want to block any opiates if they take it in one way or the other. it is a possibility. Definitely, it is not a first choice. And finally, what happens if a person is on Suboxone and he experiences acute pain? For example, somebody who is on Suboxone who had car accident and broke his femur, or somebody who had all of a sudden appendix that is inflamed, need to have surgery, and any reason. What should we handle that? First, we need to understand that Suboxone is very strong analgesic. In fact, milligram per milligram, if it is IV, the buprenorphine is 30 times stronger than morphine. I remember in the late 80s, I used to use it in injectable form for people after the most painful surgical procedure, like thoracotomy, where they cut the thorax for either lung tumor or empyema. We don't see those cases as much now. That we used to use to inject 0.3 milligram of Suboxone, of buprenorphine, medication called Buprenex, and they did extremely well with it. And also we need to understand that as I said, the injectable is approved by FDA for pain. Belbuca, if you put the film here, is approved by FDA for pain. But if you have patch, which is Butrans, is also approved by pain, except sublingually is not approved. It is really, I am surprised that it's not approved yet, because if it becomes approved for pain, I mean, there is no more stigma. Its use can be much more popular, and it can be really one of the main treatment for chronic pain condition, and it is very safe. I believe why it's not approved yet is beyond me. I believe there is no. I think the government, so NIH, the National Institute of Health, should sponsor studies to find out if it does indeed provides pain relief or no. I remember we had a patient in our practice. She had 3 back surgeries, Polish lady, and I gave her oxycodone, 10 milligram 3 times a day, and she told me it's not working. There is another medication, we have it in Poland, it works much better. She lives in Atlantis. She took the bus and she came back, and she showed me a bottle of medication, buprenorphine 0.4 milligram, and she said, I take 3 a day, and my pain is alleviated. So here you can calculate that she's taking 1.2 milligram per day for somebody who had failed back surgery 3 times, and it is working for her. And I believe we are missing the boat here. So to summarize, if somebody does have acute pain while he's on Suboxone, we don't need to stop the buprenorphine. We can give full agonist, like whatever we want to give, fentanyl or oxycodone, in addition to the Suboxone on top of that, and they will have pain relief, and they don't require higher dose of opiates to affect or to experience pain relieving. The summary of what we talked about is, we'll summarize it quickly, that we have tools, we know how to to control withdrawal symptoms when we start Suboxone, especially precipitated withdrawal from the Suboxone, and that is giving more Suboxone. We have medication that can help clonidine and antizanidine. We can give other medications also. Only in very severe cases we have to send them to hospital to treat severe withdrawal symptoms. The regular dose is the dose that is sufficient to enable the patient not to use opiate. We have to bear in mind, like we said, that pregnant women do require more medication. We discussed when we should consider injectable, and that is when the milieu, when the social issue, when they have they are unable to come on regular basis. We should or when there is problem with transportation, and we discuss how to treat Suboxone acute pain, either from trauma or for surgery on people who are with Suboxone. So if anyone has any question, please go ahead. Thank you. Next topic, by the way, in 2 weeks I'm going to talk about from JAMA. There is an article about the management of chronic of knee pain, a review article in JAMA. Take care. Bye. Any question, please go ahead.